Clinical cases. BONDBOND can be used by itself or combined with other bone graft materials to create a superior composite graft. The clinician should decide on which method to select according to the clinical conditions, taking in consideration that, when used by itself, BONDBOND exhibits higher amount of natural bone regeneration. When used as a composite graft, it exhibits longer duration of space maintaining. Case 1 describes a full mouth rehabilitation. The required procedures are as follows. 1. Extraction of impacted canine. 2. Bilateral sinus lift. 3. Implant placement. 4. Augmentation in the required sites. 5. Immediate loading with provisionalization. Post-extraction. We notice that the cavity has 4 bony wall support. This case is optimal for using BONDBOND alone. We expect a complete bone regeneration since the resorption rate of BONDBOND is equivalent to the rate of bone formation in most clinical cases. Sinus cavity and lateral augmentation. When longer duration of space maintaining is required, BONDBOND may be used as a composite graft. For example, in cases of lateral augmentation and sinus cavities augmentations. The composite graft consists of BONDBOND mixed with the dentist's preferable bone graft granules. During the sinus cavity augmentation, it is recommended to elevate the sinus lining and then use BONDBOND alone as the first layer above the lining. Then use BONDBOND as a composite graft, applying the next layers until the entire sinus is augmented. Immediate loading with provisionalization. Using BONDBOND both as an augmentation material and as a barrier simultaneously enables implant placement, augmentation, and immediate loading by provisionalization. Case 2 presents BONDBOND augmentation post-extraction of tooth number 11. A complete closure of the soft tissue was achieved after 3 months. This emphasizes the fact that soft tissue can migrate above the material. The complete closure enables and facilitates the final rehabilitation. Case 3 describes a defect smaller than 10 millimeters, with no vertical height loss, having 3 bony wall support. This is an optimal indication for using BONDBOND by itself. The BONDBOND driver simplifies the delivery of the putty to the implantation site. BONDBOND absorbs blood post-implantation due to the hygroscopic nature of calcium sulfate. This has 2 advantages. The graft has hemostatic features. The blood inflow introduces growth factors into the microstructure of the graft. After 3 months, a complete healing and regeneration of both soft and hard tissues is obtained. Case 4 describes a wide defect following implant failure. We notice a lingual and buccal plate that can support the graft. BONDBOND can be used by itself to obtain a complete bone regeneration. After 3 months, BONDBOND was completely replaced by bone. Case 5 describes mesial root fracture of tooth number 27. After extraction, we notice a large defect containing perforation of the sinus lining. BONDBOND is used for augmentation during implant placement. BONDBOND is completely replaced by newly formed bone since the material resorption is equivalent to bone formation. The bone is built only in regions where bone support is available. Thus, bone would not be built above the crest. Notice that although covered by BONDBOND, bone was not built above the implant's head, which was left exposed intentionally during augmentation. Case 6 describes a defect formed post-implant failure. The defect is surrounded by 4 bony walls. This case is optimal for the indication of using BONDBOND by itself. 3 months post-BONDBOND augmentation, a complete bone regeneration is observed. This slide emphasizes the difference between bone regeneration and bone repair. The right slide exhibits bone repair harvested from a granules augmented core showing low amount of vital bone. In contradistinction, the left slide exhibits bone regenerated core harvested from a BONDBOND augmented area, showing that a new, vital bone has formed.